Welcome to the RSNA Radiographics Podcast. I'm Maxine Kresse, Assistant Professor in the Division of Musculoskeletal Radiology at the University of Virginia. Today we will be discussing an article related to MR safety. This is an important topic that is often overlooked in traditional lectures and really important to know for the safety of our patients. The article we are discussing today is entitled MRI in adult patients with active and inactive implanted MR conditional, MR non-conditional, and other devices. This is written by Matthew Harwood et al. And is published in the February 2024 Radiographics. Active implanted medical devices, such as cardiac electronic implantable devices, spinal cord stimulators, deep brain stimulators, and drug infusion pumps, are often containing a battery and electric leads that enable patient monitoring and therapy. These devices have three categories. The categories are MR safe. Those are the ones that can be used without restrictions and without additional imaging requirements. The other category is MR conditional. So these are safe to use in specific environments and with certain requirements met. This is the focus of this article. The last category is those that are MR unsafe. The authors also suggest an additional category of MR non-conditional, and this would be for devices that have not been tested in MR environments. The use of both active implanted medical devices and the use of MRI have both been increasing in recent years, such that it's becoming more and more common to image patients with these devices. At the author's institution, for example, the yearly number of MRI examinations performed in patients with active implanted medical devices increased from just 34 in 2014 to 891 in 2022. So that's a pretty striking increase over that span of years. This article summarizes MRI safety considerations, protocol optimization, and processes to safely perform MRI in patients with active implanted medical devices. Thinking about the physics involved in MRI helps to understand the factors influential in MRI safety. First, the MR magnet has a constant magnetic field that creates a translational force, or a twisting force, also called torque, that can pull ferromagnetic objects to the magnet and cause movement of implantable devices. This force is not uniform throughout the MR scanning room, so devices are tested at the peak location relative to the magnet. It's important to check labels for this peak tolerable spatial gradient, but this is often not the limiting factor for imaging these patients. Next, the currents created by changing magnetic fields must be considered as a potential cause of device stimulation. These currents are associated more commonly with causing peripheral nerve stimulation to cause muscle twisting or spasm. Causing a cardiac dysrhythmia due to fiber stimulation would be very unlikely given the relatively much higher threshold for cardiac stimulation. So the concern is actually more related to device discharges and induced currents in metal wires. To address this, device manufacturers set a maximum slew rate, which is basically the change in magnetic field per unit time, and the MRI systems can be set to not exceed a certain slew rate by selecting high, medium, or low peak gradients. Sequences with rapidly switching gradients, such as echoplanar and single-shot sequences, pose the greatest risk. Heating is often the most restrictive parameter in imaging these device patients. Lower field strengths are often associated with being lower risk, but not always. Heating is most commonly measured by specific absorption rate, which is a complex calculation of the average rate of energy deposition in tissue with some estimation required at the time of imaging. At a baseline, authors state MRI mode should be the normal operating mode. This mode has specific absorption rate limits by body part, and this mode is preferred over the alternatives, which include first level controlled mode, which is the day-to-day mode of the scanner, or second-level controlled mode, which is the experimental mode of the scanner. The authors suggest several MRI protocol adjustments to reduce the specific absorption rate. They provide tables detailing potential protocol modifications to reduce the specific absorption rate for T1 weighted fast spin echo MRI, T2 weighted fast spin echo MRI, and 3D time of flight and Fiesta or KISS MRI, with the respective percentage of reduction achieved and resulting changes in image quality and/or imaging time. When possible, the use of a transmit-receive coil localized to the area of interest, such as the head or the extremity, as opposed to a whole-body transmit coil, will reduce heating. The authors do acknowledge that devices often require a trade-off in order to reduce heating in the form of decreasing imaging time, decreasing signal-to-noise ratio, or decreasing spatial resolution, or some combination of the above. The authors then shift to discussing safety strategies. First, they discuss the importance of training personnel, including 3 key personnel roles of MR Medical Director, which is a radiologist with the job of ensuring guidelines are established and maintained, the role of MR Safety Expert, which is a physicist or scientist, technical resource, and the job of the MR Safety Officer, which is an MRI technologist in charge of making sure safety guidelines and imaging conditions are met during the exams. The American Board of Magnetic Resonance Safety offers role-based certifications in these areas. Another important task is obtaining device information, including the manufacturer, model, and serial number. This can really prove challenging in everyday practice. It's very helpful if the patient has an information card with all this information on it, or if the device was implanted at the institution where the MRI is being performed. Unfortunately, this is not often the case, and some devices need to be identifiable by other measures. Some can be identified by radiographs. There are also some websites that are out there that can prove helpful, such as MRIsafety.com. Beyond the device identification, the status of the lead connection to the device is also important, since epicardial, fractured, or abandoned leads are a relative contraindication to MRI, given the higher risk of heating. The presence of looped wires significantly increases the risk of heating. In the scenario that a single patient has multiple implantable devices, the more restrictive device limit should be followed. There also needs to be at least 3 centimeters distance between the devices, which should be confirmed by radiographs and multiple projections. Having a proper workflow for each device category is essential to ensuring patient safety, given the number of steps needed in collaboration among providers in these cases. In general, these MRIs should be performed at a site with a higher level of resources, such as a large hospital, instead of a standalone outpatient clinic. A discussion with the individual patients on risk benefits should be had before the MRI is performed. One of the roles of the radiologist in this workflow is to assess the necessity of the MRI and if a reasonable alternative exists, such as CT myelogram or ultrasound. The article more fully details the steps and processes involved at their institution for imaging patients with particular devices, such as consultation and monitoring provided by cardiology for cardiac devices, in collaboration with the Neurology Deep Brain Stimulator Clinic for those patients. The article also details particular strategies for imaging patients with cochlear implants and programmable shunts. Thank you, Matthew Harwood and all, for writing this enlightening article. I encourage you all to check out the full article on the Radiographics website for more detailed information and examples. Also, please remember to rate, review, and subscribe to the Radiographics podcast. Thank you so much for tuning in today.